Hello, everybody. Welcome to today's program titled Confronting Partial Response to Depression Treatment, Practical Approaches for Evaluating and Treating Patients, presented by the Johns Hopkins University School of Medicine at Psychiatry Care Live. You're turned into a live session called Tackling Partial Response to Depression Treatment. My name is Dr. Glenn Treisman, and I'm the director of the AIDS Psychiatry program here and professor of psychiatry and behavioral sciences at the Johns Hopkins University School of Medicine. I'm pleased to serve as chair for this important educational program. Today's session is a live interactive program that allows us to take questions in real time throughout this presentation. I encourage you to send us your questions anytime during the program by typing them in the box at the lower left-hand side of your screen. Joining us today is Dr. Joyce King, Director of Inpatient Medicine at the Franklin Square Hospital, MedStar Franklin Square Hospital Medical Center. She is going to actually be the moderator, which is unusual for me. So if you type your questions, she'll see them on this computer over here. Thank you for joining us today, Dr. King. I really appreciate you coming over from Franklin Square.
You're welcome.
I'm going to talk a little bit today about treatment approaches to partially responsive depression, and I'm going to try to cover a couple of different things in this talk. Mostly I want to talk about why people fail and what the factors are that make them fail, and then a little bit about what we should do about that. The definition of treatment resistance varies depending on who you listen to, but one of them is it refers to patients who haven't responded adequately to evidence-based treatment, receiving adequate doses for an appropriate duration of time with two different classes of antidepressants. And the trial should be at least 8 to 12 weeks long. That definition is the definition that I think is most reasonable for us to use. And there are a number of reasons why depression is hard to treat. The most common one is that we need to think about is diagnostic error. That's not the most common problem, but it is the most common problem that we should be thinking about to start out with. Did this person really have a diagnosis of major depression, or is it something else? It's important to think about that because it changes the way you approach the patient. Inadequate dose and inadequate length of trial is very common. Patients will be undertreated or not treated long enough. Inadequate adherence, you have to always ask the question, is the patient taking the medicine? The heterogeneity of the condition, depression is not one thing, it's many different conditions that express themselves similarly. And depression can be hard to treat because your patient may have a form of depression that's different than somebody else's. Medical complications. And last, depression is hard to treat because in some patients depression is hard to treat. It's not always responsive to medications, and you have to try to find the right thing for your patient. There are numerous medical conditions that either provoke or cause depression. We're finding out that a lot of these cause depression through activation of inflammation in the brain, so autoimmune disorders and all the associated autoimmune disorders, including things as far out there as celiac disease, where people have autoantibodies to, or antibodies to gluten. Those patients have very high rates of depression. I've listed on this slide lots of the conditions that we see that provoke or worsen depression. Hypercalcemia, I'm sure all of you remember the mnemonic, psychic groans, abdominal moans, bones, and stones as the four primary factors that make you think about hypercalcemia. Patients with hypercalcemia are resistant to treatment and have bad depression. And then I've listed some of the things I work on, HIV and hepatitis C, chronic pain disorders that I work on with Dr. Clark, and lots of the other conditions. Transverse myelitis and multiple sclerosis are there. That's work done here by Adam Kaplan, among lots of other people working on it. Parkinson's, Huntington's, Alzheimer's, and syphilis, the great pretender that can appear as almost anything, including depression. So all of these conditions should be thought about in patients who have refractory conditions. Many drugs provoke major depression, and some of them make it quite a bit worse as well. The ones I always think about most prominently are steroids and sex steroids. All the drugs that affect sex steroids, like clomiphene and leuprolide, also can cause depression. And then the drugs that interact with monoamines, beta blockers and reserpine and metoclopramide, all can cause depression. And then there's lots of things that cause depression by ways we are not quite sure about. Ciprofloxacin, the other floxins can do it, but ciprofloxacin is a common cause of depression. Colchicine, again, we're not sure why these things cause depression yet, but we have some preliminary evidence for mechanisms. And it's a very exciting area of research because it's helping us model what depression really is. These are factors that are associated with resistance to treatment in major depression, recurrent episodes, melancholic features, number of hospitalizations greater than 1, non-response to first treatment, severity of the intensity of the episode, personality disorders, early age of onset, social phobia, suicide feelings and suicide risk, comorbid anxiety disorders, that probably is the most profound one, comorbid panic disorders. These things all make patients less likely to respond to your first trial, but in the long run, patients do respond. Jennifer Payne here has written a little bit about treatment-resistant depression, and one of the things she talks about is the different types of treatment-resistant depression. And the truly treatment-resistant depression that I defined in my first slide, where someone has failed multiple medical trials, can also be lots of other reasons why people have resistant depression. There's trial treatment-resistant depression, where people aren't able to tolerate your medications, behavioral resistance, where people with substance use disorders, non-compliance, or other behavioral factors complicate treatment, sedative hypnotic abuse, opiate abuse, narcotic abuse, cocaine abuse. Personality treatment resistant, in which people's personality traits complicate treatment. Life story treatment resistant, in which people's life story complicate their treatment. People with poor social support will often not take medicine, will often have a harder time responding. And then mixed bipolar disorder, which is talked about more and more because it's more and more obviously a cause of people not doing well on antidepressants, and then untreated medical illness that I mentioned earlier. And all these different things can cause treatment-resistant depression, have to be considered before you just flog away at the medications. Risk factors for resistance and chronicity include early age of onset, comorbidity, chronic medical illnesses of a variety of sorts, intrapersonal factors, social factors, and either no or inadequate treatment. Early age of onset includes a number of things. There's genetic evidence for higher familial genetic loading in people with early onset. There's likelihood of comorbidity, substance use, and inadequate therapy in people with early onset depression. And then people with early onset depression have been shown to have an altered developmental trajectory. There's a loss of human capital, reduced likelihood of marriage, but also people develop habitual ways of thinking about things that are depressive in their style and can make it harder for patients to recover. There are a variety of interpersonal risk factors that I've mentioned already, particularly neuroticism and cluster C disorders in terms of personality, and then cognition, dysfunctional attitudes, attributional style, and autobiographical memory. Memory of negative features of life can complicate depression, and then history of trauma and early adversity. Some of the social factors that so the work of Dr. David Goldberg at the Maudsley Hospital in London, one of the first people to demonstrate a variety of social factors that put people at high risk for depression, and those things also put people at risk for longer chronicity or harder to treat depression. Early motherhood, childhood mistreatment, death of a parent before age 11, childhood poverty, unemployment, low levels of marital satisfaction, low levels of socioeconomic support, and poor vocational performance. Now, one of the things that comes up whenever this list comes up, and when I'm meeting with Dr. David Goldberg, is which comes first, the depression or these problems? That is, if you have depression, are you more likely to have misadventures, be unemployed, and have poor social supports and satisfaction? Or are those things contributors to depression? And we don't know the answer to that. But whenever you see these kind of lists, you have to think, is this causal or associative? And in this case, we don't know yet whether it's causal or associative. Now, the other thing that we need to talk about a little bit is what depression is. Depression is a symptom reported by patients. It's an informal descriptive reference to the patient's mental state, and it's a diagnosis. So when I say depression, I usually am referring to major depression, melancholia, the biological kind of depression we talk about, as opposed to somebody coming in and saying, I'm depressed because I lost my job. Now, they may have lost their job because they have depression, but they may also be depressed because they've lost their job. There are lots of words that people use to describe depression, and I've put a long list of them on this slide. It's important that you think about when people use these words, when they say, I'm depressed, what they really mean, and try to get them to parse out for you what their actual emotional states are. And knowing these words and others helps you to ask, Are you miserable? Are you in despair? Are you melancholic? Are you sad? Are you